Okay, we're about two after. I see Emily is here, so we're going to go ahead and get started. It's been a while. We've had a couple of federal holidays land on our Monday meetings, so it's nice to have everyone back. Um, During our time apart, there was a Lassa virus case in Iowa, and we brought in we didn't bring in. She's always been here. Emily McCutcheon's going to kind of talk to us about how that went down, kind of the testing done here, and the some of the process involved with the Lassa virus. Emily, are you on?
I am here. Can you hear me? Can you hear
Yeah,
me?
can you hear me all right?
I
Yep, we
can,
can.
yes.
Okay. I just realized that my microphone was across the desk. I'm surprised people could still hear me. So, okay,
I
thanks. Yeah.
have a presentation if you give me sharing rates.
Oh, sure. Oh, oops. Can you
Nope,
share now?
I've got it. Yep,
Okay.
I've got it. All right, everyone. Good morning. Thank you for joining. This is a very informal presentation that I just whipped up quickly. So if anyone has questions, please stop me, interrupt me. Happy to answer those questions. Can you please confirm, Ben, that you can see my PowerPoint screen?
Yes, I can.
Perfect. I never know
Let me
with
stop
Zoom which
sharing.
one of my
Yeah.
screens I'm sharing. All
Okay.
right, I'll go ahead and get started here. As Ben mentioned, there was a recent LASA response that our team participated in. And if those of you on the phone were unaware that LASA was even a situation that we were dealing with, do not feel alone. It was a situation that occurred and was handled so rapidly and effectively that it did not make big waves, which is exactly what we want to hear when something like this happens. So just a brief background to remind you guys, Nebraska Public Health Laboratory is a participant in the CDC's Laboratory Response Network, which means that we are trained and poised and ready to assist in any bioterrorism, chemical terrorism, or high consequence pathogen testing. So here's some examples of LRNB work that's been done. The B just stands for biological here, as the bio team helped with this loss of response. But as many of you know, we are the team you guys call when you can't rule out if an isolate is a potential Francisella tularensis or Bacillus anthracis. We also get called in by entities such as the FBI when white powder letters get sent. We perform the testing and identification on situations such as that. But we're also the team that gets called in for those high consequence pathogens, such as Ebola, which occurred here. Many of you know that Nebraska's biocontainment unit supported patients during 2014 Ebola situation. And we also were a team that did quite a bit of initial coronavirus SARS-CoV-2 work when that first came out. One of the reasons that we are so active in this is that the National Quarantine Unit for the entire nation is literally right here on UNMC campus, so just across the street. So the NPHL LRN team is really kind of out of necessity prepared to handle situations such as this. So I will give you a brief background real quick just on Lassa fever and virus if you are familiar with it. So Lassa fever is a viral hemorrhagic fever caused by Lassa virus. Unlike Ebola, which is actually a filovirus, Lassa virus is an arenavirus, but both considered viral hemorrhagic fever. So many people consider Lassa one of Ebola's cousins, if you want to look at it that way. It is endemic to West Africa, like many of those viral hemorrhagic fevers. And it is spread by multimimates, a lot of M's in that word. And yes, I double check spelling. But those are basically rodents, rats. So it is spread commonly in West Africa through ingestion or inhalation of contaminated materials. If you're eating contaminated rats, you may get it. If you are sweeping up your house and you aerosolize the rat droppings. That is one method, but you can also have person to person transmission because it is transferred through body fluids, just like our Ebola that I feel like many of us are more familiar with. In general, if you had to get a viral hemorrhagic fever, this is the one you would want to get. Generally, symptoms are very mild. However, they can still be deadly. In a small amount of cases, approximately 2%, loss of fever can result in death. It has only been detected in the United States 9 times historically. That includes the most recent detection, which I'm going to follow up on in just a second. And all identifications have been travel related. We have not had transmission here in the United States. So the situation overview, some of you may have seen this come through. Loss of fever kills an Iowa resident. Here's what to know about the rare virus and its symptoms. That was posted on October 29th, 2024. So just a short time ago. So how did this situation evolve? A patient in Iowa returned from travel in Liberia in early October. And then within a short amount of time of being back, the patient started developing symptoms, fever, myalgias, headache, standard things, and really was not starting to feel well. On October 22nd, those symptoms got bad enough that the individual visited the emergency department in his local community and then was transferred to Hospital A for treatment. The patient stayed there until October 26th when his symptoms exceeded Hospital A's care capabilities and they were transferred to Hospital B. On October 27th, amid trying to determine what was wrong with this patient who was worsening in symptoms, it was determined that loss of fever needed to be explored as a potential. And so testing was requested on October 27th, very late in the day. And unfortunately, on October 28th, the patient did expire, which prompted the news updates you see above. So what was NPHL's involvement in that and how did that play out? So the primary test request was actually made on October 27th. It was received from our good old friend, Dr. Matt Donahue, the current Iowa State epidemiologist, at 14:30. So 2:30 in the afternoon, we got a phone call that says, I think we have something for you. Do you guys have testing capabilities? And I will say that we are, at the time, we're one of a few laboratories within the United States that did have testing capabilities for loss of fever. The assay that we were using at the time was not thoroughly supported by the Laboratory Response Network at the CDC, but is now fully so. Specimens were collected at 721 in Iowa City to be transferred to us for testing. They were transferred via a government courier where they literally drove the specimens from Iowa City in, and they were received at NPHL at 2308. As soon as we got those specimens, we took them into our biosafety level 3 and testing commenced. As many of you have guessed by the headlines that I shared with you, a presumptive positive result was reported out at 1 a.m., approximately 1 a.m. on October 28th. So we had just a couple minutes over a 2-hour turnaround time on that initial testing request. And that is from chain of custody being signed and during sample transfer to NPHL, all the way up to all the work done in the BSL-3 and coming on out of the BSL-3 to be able to report those results safely. So what method do we use to perform this testing? A BioFire film array. Many of you on the call are very familiar with this instrument. You're using it for respiratory panels or gastrointestinal panels, but BioFire actually has high consequence pathogen testing panels as well. BioFire film array, for those of you who aren't familiar with it, is a multiplex PCR technology that provides qualitative detections. You're not going to get quantitative here. It's all going to be, do you have it or do you not have it? We have actually verified 3 of those high consequence pathogen panels here in-house since early October 2022 so that we could be poised to respond should an individual present at the National Quarantine Unit, or at any emergency department across the state of Nebraska. We first brought up in the Warrior panel in October of 2022. That Warrior panel consisted of Ebola, Marburg, and a handful of bacterial pathogens such as Bacillus anthracis, Francisella tularensis, but it did not have Lassa. Because we are aware of there being a common frequency of malarial infections along with Ebola, also another commonly circulating disease in those areas, we also brought up the global fever panel to allow for a rapid molecular identification of Plasmodium species in those specimens. The last thing we would ever want to have is not, I shouldn't say ever want to have, it is very feasible to do this safely, but it can reduce risk if we can do a molecular panel for malaria as opposed to a malarial smear when you have blood specimens of high viral titer. And then to make us all very, very happy, BioFire actually kind of merged those two panels, the Warrior panel and the Global Fever panel. They made the Global Fever Special Pathogens panel, which took all of everything from Warrior panel, added it to everything from Global Fever panel, as well as added a couple other targets. And we brought that panel up in house August 28th, 2024. So that was also just a couple months ago that fully came online. And as you can see there on the right side, these are all of the targets in that Global Fever Special Pathogens panel. This does allow us still Ebola, Marburg. We also got Lassa virus in this one, which we are very excited for and has since been proven to be put to use and allows us for that co-identification of Plasmodium species. So we not only did the initial index patients testing, but because this individual went to multiple facilities prior to being identified as having Lassa, there were multiple exposures. So there were a lot of individuals who were being monitored for symptoms. And so anytime potential symptoms arose, we were called in to perform testing. So we did 3 subsequent testing requests. Thankfully, all of those were negative, but our team was on call 24/7 for about 3 weeks' time. Never fail. These testing requests always come in the middle of the night. So we had teams here at 2 a.m. performing work, 5 a.m. performing work. I think the nicest one we got was that initial index patient, which we received at 11 p.m. All samples were reported within 2 hours of sample receipt, which allowed the team in Iowa to be able to rapidly respond to all situations that were occurring. Outside of the testing request, the NPHL also provided 24-hour support on any questions that the Iowa team had during this. Iowa is very capable of performing all of this, but of course, it's always nice to collaborate with your friends who have been in similar situations. So we assisted in talking them through multiple things such as specimen transport, how to do it safely, how to meet regulatory requirements in doing that, methods of destruction, and other situations such as that. So I think the biggest takeaway from this that I want you guys in Nebraska here to understand and remember is when things get hairy out there and you need some help, who you're going to call, that number right there is NPHL's 24/7 pager. If you think something is potential bioterrorism, chemical terrorism, or high consequence pathogen, please call us. We are here to help. And again, yeah, call us 402-888-5588. That's what I have for my presentation. Is there any questions?
No questions for Emily. Thanks, Emily. I'm going to use this moment now to get on my own soapbox. So as Emily mentioned, this patient visited multiple facilities, and there were quite a few exposures, and that included laboratory personnel. it was quite a few days before the Lassa virus testing was requested. So there were a lot of diagnostic specimens that went through multiple laboratories, and I believe there was a reference lab, not MPHL, involved as well. So we know in the lab that even though odds odds are small that specimen could contain a virus like this, the odds are never zero. So maybe use this as a motivation to take a look at your risk assessments, um, waste management. You know, what happens to these specimens after the patient's been diagnosed as a Lassa virus patient? Um, you know, how do you get rid of the specimens that are in your lab? Um, and check your communication trees. I actually want to bring this up. I found a paper from a couple years ago that was authored by our very own Peter Iwan, among others. Pete, you can tell me if you remember this, but so kind of shortly after the initial Ebola virus epidemic in 2014 and 15, physicians at medical facilities were surveyed. They were questioned about where the testing for a specimen that might contain a high-risk pathogen is done, and less than 50% of them had a clear understanding of where testing was performed. About 38% suggested that it was done off-site, and another 22% were just completely unsure. So make sure that the laboratory is on the communication tree and in the know. Should something like this happen, you want to be sure that you're informed as quickly as possible and not kind of after the fact. So that's what I have for Lassa virus. Are there any questions at this point? Oh, and if you have questions or you're looking for resources, reach out to me. Becky and I are here to help.
Hey, Ben, this is Pete. Thanks
Hey,
for
Pete.
sharing that paper. Things haven't changed much today, even though that was written 10 years ago. I do want to mention that Lassa fever is classified as a select agent, which means there's a lot of regulatory issues that need to be taken care of when it comes to the federal select agent program. So you can imagine that having multiple exposures in multiple laboratories became a big issue with them. And we were working with the select agent folks as well to make sure all the right paperwork was presented. But it's not an easy thing to deal with. Having laboratory exposures to a potential select agent is a big deal. So just keep that in mind if it ever happens. And we are there to help guide through the paperwork if that's what's needed. Thanks, Emily and Ben. I think you did a very good job with the presentation.
I just want to add to, especially with the audience that we have on the call, I think now is a perfect example of taking stock of your facility's capabilities and awareness should you have a viral hemorrhagic patient report to your facility. Are you prepared? Do you know what to do? Is your lab prepared? Is your ED prepared? And what do you need from us to help you get there? Patients can show up anywhere. This occurred in a rural town in Iowa, um, and it is the ninth identification in the United States. So we need to really recognize that we can't have the thought process of it's not going to happen to us, because this example shows that it very much can. And I urge you to think about it extensively. How many samples are collected from each individual patient? And how well is that sample transfer documented? Is the sample destruction documented? If you have samples that have a very high viral titer and you just get notified that that patient has a viral hemorrhagic fever, would you, with your current procedures, be able to track down every single one of those samples and be able to document every exposure that potentially occurred to ensure that your staff is as safe as possible? So please use this situation as a way to make us better prepared here in Nebraska.
And we have had situations of exposures with brucella in the laboratory. We've had situations of exposures to francisella as well. So it isn't just the hemorrhagic fevers. It's even things that we know can appear in our laboratories that are making headlines and something that needs to be addressed in our lab.
Indeed. Thank you, Dr. Iwan and Emily. Are there any questions at this point?
Emily, this is Anita Smith, at CHI Health. A question for you. When, if we have a patient presenting and we have approval to draw the specimen for the viral hemorrhagic testing, can we add on, or is it automatic that we could get that malaria screen?
So if you are requesting viral hemorrhagic fever testing, and it is testing that we can do here in house, because there are viral hemorrhagics that aren't present on that BioFire
Right.
panel. That panel does include Plasmodium as a target, so it will automatically be included.
Thank you.
Yeah.
Okay, we'll go ahead and move on. And again, we've got Emily McCutcheon. She is asking for residual respiratory samples. Emily's going to talk more
All
about.
right, round two. I had to take a drink real quick. Many of you may have seen the respiratory haunt that went out from our partners at Nebraska Department of Health and Human Services, with a little comment section in there noting that NPHL is requesting additional respiratory specimens this year. We have received some additional funding that will support testing of specimens that have been determined to be positive for either SARS-CoV-2, influenza, or RSV. And we would really love to have a great grasp on what's circulating in the state of Nebraska this year, especially because we have this funding available to do so. So if your facility is interested in submitting residual specimens to us, I'm going to put my email address in the chat box. Please reach out to me. We are trying to make this process as easy as possible. So we are simply requesting residual VTM or UTM with paired CT value if your instrument is capable of producing that. No orders need to be placed within our system. Again, trying to make it as easy as possible, but we'd really like to get a good understanding of what's circulating this year. So please reach out to me if you think this is something your facility can do. We've had some facilities that have been great submitters in this process so far, and we very much thank them, but would of course love to get the geographic spread across the state of Nebraska. Thank you.
Any questions for Emily? Okay, thank you, Emily. We're going to deviate from the agenda for just a quick second. We've got Allison Kaiser-Matobo with us, epidemiologist for DHHS, who's just going to give us a brief update on whooping cough situation in Nebraska. Allison, are you with us?
Yep, I'm here. So this year in 2024, nationally, we're about 5 times higher than we were last year with our pertussis cases. So we are definitely back to pre-pandemic levels. And currently in Nebraska, we have a total of 344 cases. And 78% of those have had at least one dose of vaccine. Now, of course, not all those individuals are going to complete the series. We have 7 hospitalized, and 4 of those 7 are under the age of 1. And they all had vaccine. 3 of them had had 1 dose, and 1 of them had had 2 doses, so they were age appropriately vaccinated. And we have a total of 10 cases who are under the age of 1. And of course, we're concerned with that under 1 age group because they are particularly vulnerable to hospitalizations and dying compared to other age groups. The vast majority of our cases are roughly between the ages of like 9 and 20. So it's a lot of school age, adolescent, teens, college students that are getting it. We are not seeing hospitalizations in that age group, though. It's kind of the the 4 that are under 1 that are hospitalized, and the other 3 are like older-ish, like 60s, mid 50s to mid 80s age range. So any questions? That's my update.
Thanks, Allison.
Yep.
If there's no questions, we'll go into just our regularly scheduled epidemiology updates, starting with our hospital-acquired infection AR team. Is Ishrat on the call?
Hi, hey.
Hey,
So we don't really have any major updates, but we are working on our annual reports of all the organisms that we had seen, and we're already seeing an increase in our carbapenem meds producing organisms this year. So just, that's something that we need to share, and then we're probably going to share the final count after the end of the year. Thank you.
thank you. I would like to just thank all the facilities who have been submitting those isolates to us. You guys are doing a great job of getting those in. Is Samir on for COVID-19?
Yeah, I'm on, Ben.
Hi.
So cases are slightly increasing. In the past 7 days, there have been 327 cases that have been reported to us, averaging about 47 cases per day. Hospitalization data, I haven't got the updated data yet, so I don't have the numbers for hospitalization this time. That's all from me.
Okay, thank you. Derek?
Yep, I'm here. Thanks, Ben.
Hey.
So yeah, I'll give a quick update on RSV and influenza activity. So here the past week or two, we're starting to see influenza and RSV slowly tick upwards in terms of our number of lab positives reported. With RSV, we're seeing a test positivity of about 2.5%. That's been increasing by roughly 0.5% to 1% over the past 2 to 3 weeks. So not necessarily high yet, but starting to trend in that direction. And then with influenza, I was just looking at our latest data. So it would be week ending December 7th. And this data will be updated in our respiratory report in dashboard here later this week. But preliminary, we saw a pretty big, what I would consider a big uptick in reported influenza positives. So the previous week ending November 30th, our overall influenza positivity, this is both for A and B combined, was about 1.5%. And then coming back to week ending December 7th, that positivity jumped up to nearly 6%. So definitely seems like flu is trending upwards. I know nationally, a lot of states, especially in the South and Southeast, are seeing quite a bit of flu activity go up. So not too shocking. So that might just be a sign of things to come, that flu will continue upwards. And then one thing I did want to note, and I'll post a link to this in the chat, but back in October, our respiratory disease dashboard was updated. So that dashboard will include influenza, RSV, and COVID-19 surveillance data. I don't think we've met in this meeting since that had been updated. So I just wanted to shout out that, and I'll post a link to our seasonal respiratory disease webpage where you can both access that dashboard and then our typical respiratory disease PDF report as well that we've done in past years. So just wanted to highlight that, and then happy to take any questions now or in the chat. Thanks.
Thanks, Derek. If no questions, we'll move on to the enteric outbreaks. Claire here?
Hi,
Yeah.
this is Claire. We are seeing a lot of norovirus right now. We don't need any specimens submitted directly to NPHL unless we call and request that. We'll usually have the name and date of birth for those specimens that we need. And then we're just watching a few multi-state clusters. I think we have one E. coli 0157 and a couple salmonellas. Those cases are around the eastern side of the state. So we will also call and request those to be forwarded if they haven't been already. Otherwise, I think that's it for enteric outbreaks. Happy to take any questions if anyone has them.
Thank you, Claire. Move on to arbovirus.
Hi, Ben.
Hey, Jeff.
Well, this isn't so much arbovirus as is bacterial, but I just wanted to give an update on our tularemia situation. So we'd sent out a health alert back in October, just letting labs and providers know about an increase in tularemia that we had seen. And, we actually saw a decent number of cases, and by decent number, going back to at least 1990, this is the most cases we've ever seen reported in a year. We have 26 right now. And another one that is also under review, which looks like it probably will be a case, but we're waiting for the investigation to be done on that. What's interesting is in most years, typically our tularemia cases peak in June and July. What's unique this year is most of the case, or not most, but about 50% occurred in the month of September and October. So I believe we had 12, 13 cases with onset in the months of September and October, which is quite unusual. If we look over the last just 10 years, cases with onset in September and October, that comes out to less than one case combined if you look at all those months. So to have 12 cases that late in the year is really unusual. And of those 12 cases, 7 have been the pneumonic form, so either inhalation, some way or somehow. And just kind of looking at those cases that are pneumonic, most reported some sort of either yard work or some sort of aerosolization activity, also like digging a ditch and some stuff like that. So we're kind of hypothesizing that perhaps the wet May that we saw in the eastern part of the states may have influenced this. The reason we're kind of hypothesizing that is if we go back to 2015, which was our prior very large year where we had 24 cases, a similar situation was seen. In 2015, most of the cases were out in the Panhandle. And in that year, in the month of May, we also saw a record amount of precipitation out that way. And then we started to see the cases get reported in. So we're hypothesizing that perhaps the wet May have had some sort of influence on the cases getting reported. And then with it drying out and becoming more drought conditions later in the year, this may have influenced why we're seeing so many pneumonic cases then as well. So just some things we're kind of keeping an eye on and looking at just to see if we can get a better association of, maybe what precedes these big years of tularemia. But we weren't the only state that saw this. I know Minnesota saw a record number of tularemia cases. Kansas, they saw an increase in cases. I believe Colorado also saw an above average number of cases as well. So we weren't the only state to see it, but we are certainly one of the states that saw a pretty large number of tularemia cases. So that's kind of the big update I wanted to give there.
Thanks, Jeff. Any questions for Jeff? So with an increase in tularemia cases, we can use this as an opportunity to remind our laboratorians to follow your rule out and refer algorithms, tape suspicious cultures shut, work them up under the hood, and use that 24/7 pager if something is suspicious and you can't move forward. We want to limit the number of laboratory exposures to tularemia as well. Then we've got Tristan and the TB program.
Thank you. It's been a very busy year for TB. We've had very high number of cases we are going to report out this year. My big update for the year is we continue to see pyrazinamide testing difficulties. Previously with the false resistance, and now it's raw material error. So I wanted to share that if your lab is unable to get pyrzanamide testing. We do have the capability to do whole genome sequencing with the PNCA, a mutation to PZA or pyrzanamide. So that is an option. We've worked with, I know CHI to get samples sent over to our lab to do this. If there's other labs, that are interested, we definitely can work with you. But this is an ongoing issue that's expected not to be resolved until early 2025. That would be my update from the TB program.
Thank you. Are there any questions for Kristen? Okay, we'll move on to STD program. I don't think Tammy is on. Is there anybody from the STD program to give us an update? Okay, and then we've got lead testing. Last but not least.
Yeah,
Hello,
we don't. Oh, sorry, Brian, you can go.
Hello, everyone. We don't have any updates today.
Okay.
Thank you.
Thank you. Okay, so that's the end of our epidemiology portion. Just a couple of notes from NPHL. We've received your results for the Gram Stain Challenge. We are putting together our letter of results. We're going to include a few pictures in that. The LPX survey, if your lab participated in that, I am waiting to receive the results from CAP so I can put together that review. Becky and I are going to be doing some travel across the state in the spring, starting with Gering, January 13th. We've got North Platte, Kearney, Norfolk, Lincoln, and Bellevue. So if there's any kind of training or anything we can help you out with, we'll be moving across the state in the spring. Let us know. We can stop by, or if you just want to say hi. Yeah, we'll kind of be all over. So I know on the agenda here, or do we have any new staff? We'll do a little open mic. Any comments from anyone? Questions? Okay, so at the bottom of the agenda here, it says the next meeting is on Monday, January 13th. But as I just mentioned, Becky and I will be making our way across the great state of Nebraska. So that will be rescheduled. Same week, probably, depending on some other schedules. And that is all I have for everybody. We'll say happy holidays, because it will be after the new year next time we hold this meeting. So thanks everybody for showing up. Laboratorians, you're free to sign off, and have a great rest of December.